don't really have much of a I just thought it was like.
They won't do advanced, like this guy came like showing down in her abdomen, she's like, oh no. It's like, are you serious?
Cause you're like, confused, or you know, oh, yeah.
Liver.
Right. You're finally done with this. Ready to go. I'm not ready. I don't know. Let's just do this.
No idea the liver.
The aorta, I was in my element. Now I'm in the liver.
30.
You guys know liver. How much do you remember from liver? A little bit? Good amount?
Yeah.
A little bit.
I've never seen a liver.
So we're just gonna start out just discussing liver anatomy and get into the vascular components of the liver. This lecture is gonna be broken up over 2 days, so we're not gonna have to digest 174 slides. Yeah, I know. Just some general considerations about the liver. So largest internal organ, central to life, can't live without a liver. Take good care of your livers. It's located in the right upper quadrant, but the liver being so large, it actually extends, it's situated primarily in the right upper quadrant, but can extend past midline, and extend depending on the patient's, if they have an anatomical variant, referred to as a Rydell's lobe, it could extend very low down, almost into the right lower quadrant. Size of the liver, from the upper border of the fifth intercostal space, we measure along the midclavicular line. AP measurement of the liver, so anterior posterior measurement, should be less than 15 centimeters. The liver will increase depending on the patient's size and body surface area. So, if you're a 6'4" man, you're gonna have a much larger liver than someone my size. But also will it decrease with age? So as you age, the organs start to, I don't want to say atrophy, but they diminish in size slightly as you age. In terms of the echogenicity of the liver, we can compare it to other structures that are located in the right upper quadrant, namely the kidney. We always like to compare the echogenicity between the liver and the kidney. So this was just showing comparisons in terms of descending echogenicity. So these are the brightest. So the renal sinus, the central part of the kidney, is the brightest. Then compared to the pancreas, particularly in the older populations, the pancreas becomes more echogenic because there's more fatty replacement in the pancreas. And then the liver and spleen are fairly comparable in terms of echogenicities. And then we have the renal cortex, which is the tissue on the outer portion of the kidney. Should be a little bit lower in echogenicity compared to the liver. And then the renal pyramids are essentially anechoic or very hypoechoic. This was just a demonstration of that liver measurement, the anterior posterior measurement, if you're utilizing the technique where we measure along the midclavicular line. So I know there's a lot of kind of debate about this measurement. I don't know what you guys do, the DMS students. My hospital back in New York was trying to implement this, but for years and years and years, we just would come intercostal, get the kidney in the picture, and we would just measure tip to tip. So you had the tip in the inferior portion, just kind of measure all the way out to the left lobe. So for me, that was the most accurate liver measurement. And when we would compare it to CT measurements, I was like, yeah, we're much closer with this than the midclavicular line. They told us they didn't care. They just wanted us to go midclavicular line, no matter where we are in this liver. It wasn't really a true AP measurement. Maybe the liver was shifted a little bit over here. And
I probably overestimate the midclavicular.
Yeah.
I get bigger measurements than I do, and then the intercostal is more.
Yeah. Yeah.
Because if you're even a little bit over, it's still.
Yeah, it's off.
I mean, the sites want you to do intercostal for everything.
For everything. Yeah.
If you're not going intercostal, then you're wrong.
You're wrong.
Especially for the oral thing.
Yeah. That's good to hear. Yeah, because that was a big thing that we were fighting. I was NYU letting go, and they came in the radiologist no, we like the midclavicular measurement. These are all off.
Yeah, what does that mean? Like, you're literally
Just
just
go like
Sure.
in between the ribs.
Yeah, so like you'll come
Try
in
to
between the
get
ribs,
esophagus.
yeah, and like you'll be
You
scanning,
have the kidney in the picture.
yeah. When we get in the comp, I'll work with you guys,
Okay,
like,
cool.
yeah, this is brand new for them. So in terms of echogenicities, we can determine the health of the liver based on the echogenicity of the liver, how bright it is. Particularly in cases when we get fatty infiltration of the liver, that liver will become very bright, very echogenic in comparison to the kidney. So if you put me on the table right now, I know I have fatty liver disease, and you compare my kidney to my liver, my kidney's gonna look very, very dark in comparison to that liver. And that just means that fat has infiltrated my liver and it's making it more echogenic. So we use that right kidney and liver comparison. So normally these two should be very isoechoic, very similar. Kidney should be a little bit darker, but not significantly darker. That cortex of the kidney, so the outer portion, the outer part of the tissue of the kidney in comparison to the liver. So liver anatomy. So we break the liver up into several sections or lobes. The divisions, we have the right lobe and the left lobe. So right lobe is located on the patient's right, left lobe towards the patient's left or more midline. We also have a caudate lobe and then a quadrate lobe, which is the medial left lobe. So there's a fourth lobe that's not typically imaged. When we're doing our ultrasounds, we primarily just focus on right lobe, left lobe, and caudate. So this is just showing the liver from its anterior view now. So, we're looking anterior, posterior, our large right lobe, left lobe. In comparison, it's much smaller. We have the ligamentum teres separating the right and left lobes. So this is diaphragm now. And you can see the IVC coursing, posterior to the liver. So that's why when we're imaging for our comp, our IVC, that proximal IVC, we can see it coursing underneath the liver in that sagittal view. The right lobe is about 6 times larger than the left. We further divide that right lobe into anterior and posterior segments. So we're going to learn in a moment that the hepatic veins, we use the hepatic veins that course through the liver to divide the liver further into separate segments. And then that right lobe is divided into an anterior and a posterior segment. I mentioned before, there's an anatomical variant that exists referred to as a Rydell's lobe. So this is a normal anatomic variant, it's not a bad thing if you have one. Does anyone here have one? Yeah, Jay's got one. So it's common, definitely more common in women. And basically this is a tongue-like projection of the right lobe. So it extends down fairly far inferiorly. And it could give the impression of that liver being enlarged, that patient having a hepatomegaly. Here we have a nice sagittal view of the right lobe with the kidney in the view. So here we see the right kidney, and we can compare again the echogenicities between the liver and the kidney. They look pretty isoechoic. So that's a good indication that this patient has a nice healthy liver.
Where I still have like a hard time recognizing like a fatty liver, like based on the pictures, like they'll be like, all right, that liver is echogenic, and I'm like, but it actually, I think it looks isoechoic.
Yeah.
It's like, I feel like it's a lot of them are, if it's not really bad,
Yeah.
I mean, I think they look a little bit more heterogeneous. But like I would write isoechoic on a lot of them, but
Those are obvious, right?
Are they all fatty?
Yeah, those are all fatty.
Yeah, I mean,
And the simulation, but like that one in the corner
you
down
can't
there.
even see the
Yeah.
kidney.
You could just
in
turn
the
it
picture
around.
of
I
those.
can't,
So
Yeah.
that's when like, that's usually when you know, because, right, it's hard.
Yep. So one of the first things, well,
Yeah.
I'm getting ahead, but look,
Okay.
yeah, and that's,
Anyway.
Like on here. No, that was normal. This is normal.
well, this one's normal, where you go.
There.
There we go. So yeah, this is normal.
Yeah.
So I mean, it's fairly isocolor. I mean, the kidney will look very, very dark in comparison, and this will get much, much brighter.
Do we need to worry about
If you're doing hepatic vasculature,
it?
you won't be, you guys be doing echoes. Don't be the echo techs that start diagnosing liver masses when you're doing your subcostal views. So like I had a big, I was working in the general department, all of a sudden we start getting all these abdominal ultrasound, rule out liver
I
masses
wouldn't even know.
and liver lesions coming from the echo department. So someone in the echo department was scanning hearts, and then we come subcostal through the liver to image the heart. And they were like supposedly seeing all these liver lesions that,
I never know if there's anything wrong with the liver.
I don't know, yeah, it was someone overreading an echo.
I just look at my IBC coming through there and I hope that there's something huge on the screen. A little ball.
So left lobe liver. So the right and left lobes are separated by the falciform ligament. We also further divide the left lobe into a medial and lateral segment. So the left hepatic vein will actually separate the left lobe into medial and lateral segments. So right lobe is separated into an anterior and posterior segment. The left lobe is separated into a medial and lateral segment. So don't get confused when you're labeling your segments in the liver, particularly for the left lobe. So the medial segment is in relation to the organ itself. So even though the medial segment is more medial in comparison, like to where it lies in the body, you know, particularly if like it's the left lobe kind of like comes to here, like the lateral segment is here kind of more midline, and the medial segment is actually a little more lateral, like, yeah. So just think of it in relation to the liver. So this is the lateral segment of the liver. This is the medial segment of the liver. Here's a sagittal view of our left lobe of the liver now. So it kind of looks like a boomerang, right? Is that what you guys described it as? Shark tooth. Yeah, it does look like shark tooth.
So then from that picture, how would you distinguish medial and lateral, you're saying?
You're not in this picture. You're in transverse when you see the hepatic veins.
Okay.
So this is now a posterior view. So we're now looking at the liver from behind, and you can see a couple of things. So here we have the gallbladder. So the gallbladder sits posterior to the right lobe, and there's a fossa, kind of a little indentation and groove in the back of the liver where the gallbladder sits. You can see some of the vasculature. So you can see your IBC. Here you can see the caudate lobe now. So that's left lobe, right lobe.
Should we know that one, like by what the is?
This one, no.
That test was on our app,
exact picture.
that picture was on our abdomen, but we had never seen it before, and royally.
Blew up.
And PTSD.
So caudate lobe, surrounded by the ligamentum venosum, anterior to the left, the IVC posterior to the right, and the porta hepatis inferiorly. The unique thing about the caudate lobe, it's functionally distinct, so it kind of operates on its own, independent of the rest of the liver. So that's why a lot of times when you see patients with cirrhosis, their left lobe and particularly their caudate lobe looks huge in comparison to their right lobe. They'll have a shriveled up, terrible looking right lobe of the liver, but their left lobe, and particularly the caudate lobe, it's massive. Because it's functionally independent. It has its own venous drainage and drains directly into the IBC. So particularly when there's portal hypertension involved, that portion gets spared because it's able to drain itself out. It's not under that same stress and pressure that the rest of the liver is being subjected to because of portal hypertension. And then we have the fourth lobe, the quadrate lobe. So this is surrounded by the porta hepatis superior, the GB fossa, gallbladder fossa, lateral to the right, and the ligamentum teres medial to the left. So I'm not asking you to memorize like all these, you know, what lies here, what lies there, you know, what's anterior, what's posterior. That's DMS.
Label a caudate lobe, the text will yell at you. They're like,
Yeah,
that,
they're not
that is
labeled.
actually made up.
Really?
They're like, forget that. Every time I've labeled it.
So we just need to be able to.
Oh, that's the picture.
Yeah, that's.
Oh. The impression. I'm like,
Here was a transverse view now,
thing.
for the demonstrating the caudate lobe. We see a portion of the left lobe of the liver. You can see the IVC, so this is the large IVC. So now we're in transverse for the liver. Little piece of the left portal vein. And this is sagittal view of the caudate lobe now. So here's the caudate lobe. And you can see it well visualized here. So this is sagittal now. So you're just kind of just like midline. Well, not really midline. Well, I guess you're kind of midline angling more towards the right. And the IVC comes in with the left lobe of the liver. So here's the left lobe of the liver, sitting anterior to the caudate lobe. The caudate lobe behind. So these are both sagittal views. This was just showing the gallbladder here, with the main lobar fissure extending out from the gallbladder. If you ever asked to identify that, maybe some of the DMS students. The main lobar fissure.
Oh, yeah, we.
Yeah, but it's like a gallbladder fossa without a prominent falciform ligament or on a fatty liver. What do you, it's just a dense.
Yeah, it's just, yeah, you're not gonna see it.
I had to do that the other day, all of
Here you can see
like,
that's a
fine
nice
fossa.
name.
A gallbladder, all I do is go to the
I just-
portal,
I just go to
go to the portal vein.
That's
and
what
then
I did,
stand up
and I
a
was
little
like,
bit. That's pretty much all they do. Yeah.
It's right there. Just
You're
like,
sitting and just, there you go.
Oh, I'm so
Duh.
You sound confident. I really have skin issues because I could do it.
Alright, so liver division. So I mentioned that the right and left lobes are broken down into further segments. So that right lobe is divided into an anterior and a posterior segment. So here's our inferior vena cava and your three hepatic veins now. So you have a right hepatic vein, a middle hepatic vein, and a left hepatic vein. So middle hepatic vein splits the liver into right and left lobes. To kind of think of that as like your equator almost, or, you know, splitting right and left lobes, the middle one. The right hepatic vein, if you kind of visualize it coming across this way, it divides the liver, the right lobe of the liver into a posterior. So this is, you know, if you're coming anterior, this is anterior, posterior. So just think about it, your anatomic positions. This is the posterior portion of the liver. This would be an anterior portion of the right lobe of the liver. So right hepatic vein divides the right lobe into anterior and posterior segments. And then the left lobe, left hepatic vein kind of comes up in this direction. And it splits the left lobe now, so if this is all left lobe, splits it into your medial segment and your lateral segment. So this is the lateral portion of the organ, this is a medial portion of the organ. So middle hepatic vein splits liver into right and left lobes. Right hepatic vein splits the right lobe into anterior and posterior segments. Left hepatic vein splits the left lobe of the liver into medial and lateral segments. So this one, I want you guys to be able to label and
Okay.
your segments and your vessels. Yeah, this ultrasound image. Yeah, don't worry about the diagram, the image.
You mean just the ultrasound?
Yeah, just the ultrasound image. Yeah, good. This is just another diagram, again, just kind of explaining what I said about the hepatic veins dividing the liver into those additional segments. There you go. There's it nice and big. Right anterior, right posterior, left medial, left lateral. And you got your hepatic veins all labeled on there. Yeah, this one's way better. So the liver functions. So the liver is responsible for making certain chemical compounds such as bile, lymph, albumin, fibrinogen, globulin. Liver is also involved in carbohydrate, fat, and protein metabolism. Liver produces heat as a result of that metabolism. It also acts as a short and long-term storage for nutrients. Removes toxins, store blood as well. Serves in detoxification and excretion of waste. And the liver is unique because the tissue can regenerate. So it's one of the organs that can kind of regenerate tissue, which is pretty impressive. One of the main conditions, particularly here in the US, is fatty liver disease. So result of bad diet, eating too much carbs, poor lifestyles, being obese, that excess glucose gets stored in the liver, and the liver becomes fatty, it becomes infiltrated with fat. So these are just examples of patients that have fatty liver disease. So you might see it on the script as hepatic steatosis. That's like one of the medical terms for fatty liver disease. One of the main things that you'll see with fatty liver disease is you have decreased penetration and increased attenuation. So that ultrasound beam just gets absorbed and doesn't actually penetrate all the way through the liver. So this is the diaphragm. So normally you should be able to scan completely through that liver. It's a very vascular structure. So it has very good through transmission. Ultrasound beam can get through it really easily. But in this case, once it becomes fatty, we've lost all of that power of the ultrasound beam. And down here, we're barely seeing that posterior aspect of the liver. So you might have to really crank up your TGCs, your gains to be able to try and visualize that. With fatty liver disease, one of the other things I look for is loss of visualization of the vessels and the bile ducts. But particularly the portal veins. So we'll see in a moment, the portal veins have bright echogenic walls to them. So if I can't really define and visualize a lot of the liver vasculature and the vessels within that liver, I know right away that it's fatty. Like I don't even have to compare it to the liver. So like in this case, I don't see any vessels as I'm looking at that. The liver also takes a more coarse looking appearance to it. So instead of being nice and smooth and homogeneous, this is a more coarse appearance. I mean, this looks fairly homogeneous, but again, I'm losing a lot of the definition of that vasculature. I'm not seeing really the vessels very well in that. This one, you can barely even make out what's going on there. You can just see a little bit of that diaphragm here. So you're over the liver, but again, these are all examples of patients with fatty liver disease. And unfortunately, that's kind of like the issue. So these patients are coming in for these liver vascular, like to assess the vasculature of the liver, they have cirrhosis and the livers are all scarred, fibrotic, or maybe they have fatty liver disease, they have bad liver function, and they want us to assess the vasculature, but we can't even see the vessels at that point. So it's like, all right. So the studies become quite difficult, unfortunately. So this was examples of diffuse fatty infiltration. So the whole liver is fatty. There's no focal areas where that fat is collecting. But we can also have focal fatty infiltration where those fat deposits are, located in a specific spot or region. So in this case, we can see the area here. It's very bright, very echogenic compared to the rest of the liver. So these are areas of focal fatty infiltration. This focal fatty sparing, we can also oftentimes see it adjacent to the gallbladder. So that's another nice common spot where we see focal fatty infiltrates is adjacent to the gallbladder. blood supply. We touched a little bit about this on this, I think maybe one of our first vascular classes. So the liver has a dual blood supply. So there's two vessels that are bringing blood flow to the liver. We have the hepatic artery and the portal vein. So we describe blood flow that's traveling into the liver or towards the liver as being hepatopedal. So that's the term that we use to describe blood flow that's traveling towards the liver. So with that dual blood supply, the hepatic artery supplies about 20% of that blood flow that's going towards the liver. The remaining 80% comes from the portal vein. The hepatic artery brings oxygen-rich blood to the liver. With the hepatic artery, we have the common hepatic artery. It's that main branch off of the celiac axis. The common hepatic then branches into gastroduodenal artery and then the proper hepatic artery. So the proper hepatic artery is the one that ultimately ends up in the liver and enters the liver in an area referred to as the porta hepatis. So we'll see, we have some pictures. I'm gonna show you guys where the porta hepatis is. So that's where the vessels enter and exit, as well as the bile duct enter and exit the liver. Anatomic location of the hepatic artery should be anterior to the portal vein. That proper hepatic artery, once it enters into the liver, will then split into a right and left hepatic arteries, supplying oxygenated blood to the right and left liver lobes. In terms of resistance, the artery going to the organ, so it should be low resistant flow. So it should look similar to an ovarian flow. It should look similar to an ICA. So it's organ flow, low resistant flow. Hepatic artery is also fairly small in caliber. It's about 6 millimeters in diameter. So it's small. It's about half a centimeter. So here we can see celiac axis, celiac artery. We have the common hepatic artery, is that first branch. And then that common hepatic artery then splits into several branches. We have the gastroduodenal artery, heads down towards the pancreas. The proper hepatic artery is the one that continues on towards the liver and enters into the liver, and then splits into your right and left hepatic arteries. And then we also have a right gastric artery that's also a branch off that common hepatic.
We need to label this picture.
Yes, it's on your quiz. I will check. I'll let you know. Question mark.
I feel like we know most better.
So here's our seagull sign now. So this is now a transverse view of the proximal aorta at the level of the celiac artery. So here's aorta, celiac artery coming off anteriorly, coming right at us. And then the first branch is that common hepatic going out towards the right, towards the patient's liver.
Is that the seagull?
Yep, it's the
Oh,
seagull.
that's what I had on Kindred.
Yeah, she's a good scan for this. It does look like it in color. You don't see a bird? No, a T?
Like a drawing.
It looks like
Remember
an
how you used to
IUD.
draw the
That's what I was
bird?
Looks like an
saying.
IUD.
Like the M.
Didn't you used to draw birds like, yeah, like this.
I still draw birds like that.
Are you doing? Girl.
So normal hepatic artery Doppler flow. So again, it's bringing blood flow to the liver, so it should be continuous forward flow, nice low resistant flow pattern. So here they're Doppling the celiac artery. Low resistance with continuous flow throughout diastole. So here we're getting towards the liver now. So here's that proper hepatic artery now. And just trying to get your bearings. So those of you, you know, that are in CVS, this is gonna be kind of like a little bit of an oblique view, a transverse oblique view. So the hepatic artery should sit above or anterior to that main portal vein. Running side by side with the hepatic artery is gonna be your common bile duct or your CBD. Here we can see a bile duct.
I hate the common bile duct.
We got good.
But I really don't even think that's it. And they were measuring it, I was like.
And someone.
No,
like,
no.
Like, yeah, that is it.
No, because you have to measure the common hepatic and the.
Yeah.
Yes.
Nobody does
And the
that.
common bile.
There's no way.
Most of them don't measure that. Yeah.
They're starting to. Yeah, all the hospitals do now.
So the common bile duct is a duct that drains bile out of the liver and puts it into your intestine, into your small intestine to help break down, is it fats and proteins, right? Fats and proteins. Yeah. Or sounds good. Fats and proteins.
Sounds right.
Sounds about right.
You would do more than us.
Didn't you just,
Yeah,
sounds
sounds right.
You said carbohydrate.
So this is now a transverse picture of the pancreas. So this is pancreatic tissue. This is actually the head of the pancreas. And in the head of the pancreas, you can visualize two structures, two round circles. One is going to be your gastroduodenal artery. So the more anterior one is your GDA, gastroduodenal artery, and the one that's more posterior is going to be your common bile duct. So you can tell the difference between the two when you put your color on. One of these is going to fill with color, one is not. So the bile duct will not fill with color because it's not a vessel. The bile is just moving very, very slowly. It doesn't, the machine doesn't pick up any, movement of blood or the movement of the bile. It'd be crazy if it did.
Mine fills.
I'm sorry?
Mine fills with color.
Yours?
Yeah.
You're, really? You're
Yeah,
serious?
like hunting for it.
I mean,
like
we've
30
only ever
minutes,
scanned
just-
on our machine.
Yeah, so like
The
that.
color
could be
on
the
our
problem.
machine is not.
Yeah, but it
It's
does,
really
but mine does fill with color, yes.
Wow.
Yeah.
Flexing that gallbladder, man, like.
This is like a fluke, like she's been scared.
It's been scanned.
So good. Does it every time.
Alright, so what would be vascular without pseudoaneurysms?
Ah.
So pseudoaneurysms, can exist off of the hepatic artery. So again, pseudoaneurysms, regardless of whatever artery they're coming off of, will have the same characteristics. You'll have that yin yang appearance within the actual, pseudoaneurysm itself. If you have a good neck to Doppler, you'll get the bidirectional flow with the Doppler. That's a really kind of crappy Doppler picture. They probably have a really bad angle on it. But again, pseudoaneurysms, regardless of where they are all gonna have the same characteristics. And this could be a result, maybe they did a biopsy that they messed up and they hit the artery somewhere. Maybe they're doing a liver biopsy, maybe they're doing some sort of interventional procedure. Maybe it'd be a result, this was a patient that had pancreatitis. So that pancreatitis, the inflammation of the pancreatitis damaged the vessel. Within the liver, we can also encounter arteriovenous malformations, so AVMs. These are basically like little fistulas, within the liver. So connections between the arterial system and the venous system. So if you think about that, the flow patterns that we have in fistulas, it's very fast, very turbulent flow, particularly in the venous side. We see, cardiac pulsations and what's venous flow, very fast, elevated velocities. We see increased velocities in the arterial segments. So if we're Doppling hepatic arteries within the liver itself, these are going to be very, very low resistance with elevated velocities. And when we put our color on, it'll look like a tangled mess of vessels. So when you put your color on, you'll see it'll just light up and fill with color. And that's not normal vasculature, when we're talking about the liver. So portal vein. Portal vein, so this supplies the remaining 80% of blood flow that goes to the liver. So the vast majority of your blood flow that's going to your liver is via the portal vein. So this supplies nutrient-rich blood from the digestive system, and it brings it to the liver. So then we call this hepatopedal flow. The portal vein originates at the junction of the splenic vein and the superior mesenteric vein. So the splenic vein and superior mesenteric vein come together to form the main portal vein. That main portal vein then courses towards the liver, enters into the liver at the level of the porta hepatis, and then splits into a right and left portal vein. So right portal vein goes to the right lobe of the liver, left portal vein goes to the left lobe of the liver. In terms of orientation or location, it's anterior to the IVC, so it's above the level, above the IVC when we see it on ultrasound. Yeah, what,
Sorry, we're just, I'm sorry.
no, it's okay.
It's okay.
No, tell me what,
Stupid questions. I was just getting confused with the direction of the flow. Yeah,
so
because
have,
I'm thinking of the heart where arteries are always coming out. Does that, you know what I'm saying?
yeah,
So I was like, I was getting confused how the artery and the vein are both hepatopedal. Cause I'm thinking of,
It's like a weird.
Yeah,
I'm thinking of the
this
heart where
is like-
only veins come in
yeah.
and arteries go out.
They're not the,
yeah.
Yeah.
It's like.
they're not both going to the same, they're going into, they're different systems.
Mhm.
Yeah, this is so like,
This is just so backwards from the heart.
yeah, it is, it's different, cause this blood has to go to the liver first, and then the hepatic veins drained it into the IVC, and then it gets back to the heart.
Yeah.
Cause I'm just thinking of how arteries never feed into the heart. They only go away.
Yeah,
So that's what my brain keeps telling me, that the artery can't be bringing blood to something.
yeah, this vein brings blood to something.
Well, the arteries, what I was
Yeah.
confused about.
Yeah, well, the arteries, yeah, bring blood flow to the organs, always bring blood flow to an
But
organ.
not to the heart.
So I think of it as like there's an
Yeah,
arterial
yeah.
system, a venous system, and a
Well,
portal system.
this would like be coronary arteries, so the coronary arteries are the one that are supplying,
Yeah.
Cause
I have the
heart. I'm just kidding. But it's okay.
yeah, the heart, like, think of it like a, yeah, I know what you're saying.
That was like Shauna like grilled that in and she was like, artery starts with an A because it goes away.
It could be, so like, think hepatic artery, like the coronary arteries, and then,
Mhm. Okay.
So everything
IVC.
pedals towards the liver
Mhm.
and the fugitives are wrong.
Okay.
That's what we learned.
Fugitives run away.
Hepatopedal or hepatopedal.
Yeah.
So pedal towards fugitive
Okay.
is wrong. I don't know if that helps.
I'm okay.
okay, alright.
Kind of.
So this is gonna have a low velocity venous signal to it. There should be a little bit of phasicity to it, so particularly if you like, optimize your Doppler settings and you decrease your scale, make that waveform larger, you should see a little bit of phasicity to it. Might be a little pulsatility also, depending if the patient has any sort of cardiac issues, if they have like congestive heart failure, you might pick up some pulsatility to it as well. With the main portal vein, flow will increase after you eat. So if you just think about it, intuitively, I just ate a big meal, body's digesting all that food, so extra blood going to your gut. So now it's gonna take all that food that you just ate, bring it to your liver, all that, hopefully you ate something healthy.
As we're eating chocolate chip.
So the flow in the portal vein will actually could double. So velocities and the amount of blood flow in that portal vein can actually double after you eat. So that might be a good thing too, like if you wanna rule out, like portal vein thrombosis, say the flow is very slow. Test them after they've eaten, and you might see all of a sudden, oh wow, there is flow in that vessel, or, if you wanna look at like. That's probably the main thing, if there's thrombus, if you're worried about that vein being thrombosed, the flow will increase after you eat.
So they're not fasting if you're doing liver study? They should.
Yeah,
It's
you
not
are.
just raw. No, that was like, unless you're specifically looking for portal vein thrombus.
You could, yeah, that's one thing. I've seen a couple board questions about that.
I remember you telling the second year stuff.
Wait, so,
The old second years.
so what study would that technically be?
I would say maybe if you were scanning and they wanted to rule out portal vein thrombosis and like the flow was so slow that like even power Doppler didn't pick it up, you can, after they've eaten, that might be enough to like, I want to say not spur, but like increase flow volume to allow you to visualize the main portal
So
vein
you
as
would
being
do
patent.
that, like, within the study?
No, I would send them back, have them.
Well, that's
eat.
what
Bring them back
Yeah,
for like
bring
a
them back.
limited.
Yeah, bring them back for a limited, yeah. Or the doctors, yeah, be like, well, I'm not really sure, like, I can't really tell if there's flow in this or not.
So is that when you would put in there, so something like can't exclude portal
Can't
vein
exclude
thrombus
flow,
or-
yeah.
And then they can decide if they wanna look at it more.
So,
I love cannot exclude. Yeah.
so one of the main measurements you need to memorize for main portal vein is 13 millimeters. So you can circle that, star that. Initial that. 13 millimeters is your normal caliber for main portal vein. So diameter of 13 millimeters. When you start exceeding 13 millimeters, we start worrying about portal hypertension.
You said bigger than 13?
Yeah, larger than 13 millimeters.
Um,
That's with quiet respiration. So just normal breathing, regular breathing, 13 millimeters. Yeah. Portal hypertension. So here's, the portal vascular anatomy. So you have to think of the portal venous system as kind of its own system. So we have arterial system, venous, regular, systemic venous system, and then we have this portal venous system. So here we can see the main portal vein. Again, that's formed by the coming together of the splenic vein. So it's a little segment of the splenic vein and the superior mesenteric vein. So those two come together, form the main portal vein. We have the inferior mesenteric vein, which drains into the splenic vein. So that's actually a tributary of the splenic vein. So here's spleen way out here. We have that long splenic vein, and the inferior mesenteric vein joins the splenic vein. Splenic vein continues, so for a little segment, and then the SMV comes up and joins the splenic vein to form the main portal vein. The main portal vein continues towards the liver, and then once into the liver, it branches into your right and left portal veins. School.
No.
That's the worst. Mr. Hernandez, I'm here with your son. He's just vomited everywhere.
Well, that would be for you.
If I come like there's slow.
It's
You're like,
literally
yes,
the worst.
oh,
It's
it's weird.
like, never good, never good.
They're never calling to say your child's doing.
Your child's doing great. Keep it up.
All right.
Period, Daniel. It's some of cool here. What they do? What?
I don't know. I don't know. Yeah.
Oh, you can leave.
No, I don't have to leave. No.
They want you to leave.
I can just tell her, call my wife, like.
I was wondering, but I was gonna do some. It's Hollister just started it. It's like they do like pajamas and activewear. Yeah. It's like by Aerie. It's like it's like Aerie but for Hollister.
I love Aerie.
Me too.
So comfortable.
And their pajamas are so comfy. I have a pair too. They're so. They're kind of expensive. I go to Target for my size. Brody, how many weeks are you? 14. Wait, second tries. Oh,
Oh my
shit, they did now. Brittany, I knew I started. I wasn't. I swore they were here. No,
You guys must have literally.
No, I just heard it from someone this morning.
No, I swore that you guys were sitting there with.
Oh, no, they
I
don't say that. Oh, I thought you guys were standing right there.
Yeah, Brett's having baby meat for her.
Oh, this morning, I said you're 15.
I want to see your baby when he's older so we can make him feel.
Yeah.
May I? She wants to.
I am a baby farmer.
You know what, that's good, because I'm the one who gets like the results for my brother's next kid, I got it yesterday, and that's a boy, so maybe, and like, having a boy, there's boy vibes.
Boy energy. Boy,
There's a lot of boy vibes.
Are you really sick? Anybody got a name for Noah? Middle name?
Noah Silence.
How would you have all
Liam, middle name's Noah.
Noah, yeah.
Yours, what?
Oh,
Noah?
Wait,
what's the name?
yeah, we should probably gonna have a boy.
Good
then.
sense of, yeah.
Girls think about the game, like, I almost died with my girl, getting sick, like, I was sick forever.
Lots of, like, all the wives too, like,
We have
PR mouth.
We were friendly. I usually don't eat them
We did what's his middle name? TJ.
Because I have to.
Love Mark.
I know, but I don't know. Like, when I was standing, I was like, I'm pushing it over hard, and I was laughing, like, yeah, like that, and I was like, girl. 15 pounds. And then, well, how much will you weigh? 0? I'm like, that is like, I like a little bit, I like Elmer.
I love Elmer.
Yeah, well, like,
I just like the name of Lauren.
that's not healthy.
Rock Lauren.
Oh, like, and you put a Larry.
My oldest daughter.
That
was
really
really
sounds
sound. I just think she only look at those.
We had another boy where that was gonna be a.
I just can't pretentious.
That's all. No such luck.
Just wanted to say the family names to be Andrea, which I don't know if anyone says it is, but like.
No,
It got more, there's like, you're not trans, and he was like, I want his middle name to be a trans. It wasn't trans on the office.
Oh, cute. Because next time, boyfriend.
I told you I had a woman naming her baby Zelda. She's like, yeah, I was a video game character. I said, oh, that's so different.
I'm really thinking on having a girl when it comes to my time, because of it's gonna be the third, and my boyfriend's middle name is Scott, and his first name is Michael, and so that child's name is gonna be Michael Scott, and then. And we are really
Do it.
the office.
Scott's the third.
It's gonna be Michael Scott.
I'm so
My
glad that we
friend-
didn't name Jackson.
My friend's kid is Michael Scott III. The
I
person I
wasn't
told you
quite
about,
sure.
who
I
also
wasn't
thinks
quite
Michael
sure.
Scott.
I need to have a.
Michelle Scott.
Michaela.
Michael Scott, yeah.
I'm so weird, so we're just gonna. No.
I mean, I gave Jackson.
I know, cause girl, you
Too much.
it's good with that butter.
I know, that's what I do. I
Next
try.
week she's gonna be like, I need to lose 20 pounds.
I gotta remember here, but I like.
Right. And then I went, and they're all talking about it. They already can barely see me, there's nothing to push into. She could just.
No,
No, you have.
So mad.
So
It's by the way.
Do not let her. Actually, on my first Friday, I was like, but I was like,
Tristan messed up.
and I was muscular too, though. and I was
Here's
Like,
supposed to be.
you're not one of those.
Let's go.
Alright,
Just tell him.
I know.
Yeah.
It's like,
alright, so here's our, DMS students are tremendously familiar with this view. So this is our transverse view, level of the pancreas. Yes. That was actually this week they played that song. So we're transverse, essentially midline, transverse. So we can visualize our superior mesenteric artery, we can use that as our nice landmark. That's that nice echogenic mental fat target sign. We have aorta, inferior vena cava. But in terms of the portal vasculature now, you'll see the vessel kind of dilate, almost make like a little circle here, and this is the portal confluence. So that's where the splenic vein and superior mesenteric vein join or form, come together to form the main portal vein. So we refer to this area underneath the head of the pancreas as the portal confluence. So in a transverse view, when we're at the level and we see the portal confluence, the vessel that's draining into that portal confluence is your splenic vein. So in transverse, we see splenic vein. So it's important to recognize that whether or not you're in transverse versus sagittal, because when we're in sagittal now, instead of seeing the splenic vein, we're gonna visualize, the superior mesenteric vein draining into that portal confluence. So just rotating your transducer from, transverse to sagittal will completely change what vessels you're visualizing. So good tip, just kind of look at your aorta and IVC, see if they look transverse. Are they circles or are they elongated? And you know you're in a sagittal orientation. So can you label your vessels?
That's the one we should look at for the test. for the exam.
So we call one the portal confluence.
Portal confluence, yep.
And then.
Splenic vein is two.
Yep.
SMA.
SMA.
And IVC.
IVC, yeah.
Mostly not.
I'm gonna have a hard time scanning this.
Yeah.
Me too.
It's all brand new to you. That's, I know.
I still can't remember the indicator. I think going past some consoles, putting it at 3 o'clock.
So here we can see the main portal vein now. Entering into the liver. So here's the porta hepatis. So here's the border of the liver. Entering into the liver at the porta hepatis. And then once it enters into the liver, it branches into your right portal vein. And then I'm not seeing really the left one, maybe a little piece of it, but the left portal vein go out towards the left lobe of the liver. So this is patient right, patient left. And then in transverse view now, so you can see the SMA is that little circle, we know we're in transverse. We have that portal confluence, and then this is the splenic vein draining into the portal confluence. But if we rotate into a sagittal orientation, so now the IVC is elongated across the bottom of the screen. That portal confluence now has the superior mesenteric vein draining into it. Yeah.
So in transverse, it's the artery and longitudinal, it's the vein.
In transverse is the splenic vein draining into the portal
No,
confluence.
I mean for, like, in transverse, we see the SMA, right?
Yes, yeah,
So then, but then when we turn on it, we're seeing SMV and not SMA.
yes, yeah, to get SMA, you would, in this plane,
Once you turn the SMA
yeah,
on.
so you're tilted a little more towards the right. I'd have to angle towards the left, towards the aorta to see the SMA coming off the aorta.
Mhm.
But
Yeah,
yes,
you're just in a
yeah,
different.
you're just in a
it's
different
a
plane,
plane.
yeah. Yeah, you're in a slightly different
But in
plane.
the
A
same
lot of
spot,
people, you can't even see that.
like, are we moving with, like, are we just literally just turning on the?
Literally
camera?
just turning, but in trans, so like. SMV and transverse would probably be somewhere like. In here, maybe coming up, like, you're not really seeing it here.
We were taught for the pancreas to look for like the SMA.
Mhm.
And like most of the time, like in any difficult patient, like all the texts were like, don't even look for the SMA because it's so hard to see
Okay,
on a lot of the patients.
okay.
So.
It's not worth it.
Popular spot for a gas bubble, I feel like.
Yeah.
Yeah, every time, every time.
So normal portal vein waveforms. So they can vary a little bit depending on the patient's age, again, their fasting status or MPO status. Their cardiac status, you know, whether or not they have congestive heart failure or portal hypertension. So different things can affect that portal vein flow. So in this way, that one, the top waveform that showed more pulsatility was from a very thin individual. The important thing with the portal vein flow is that it's unidirectional, that it only goes in one direction. So it doesn't, you know, touch the baseline, it doesn't go below the baseline. This is probably just artifact, to be honest. Turn that down. But normal portal flow should only be in one direction. Should only be hepatopedal going towards that liver. So this is a good example of main portal vein coming up towards the liver. So in this case, red indicates blood flow coming towards the transducer, so it's proper flow direction. Portal vein flow can be blunted by a deep inspiration. So if they take a deep breath in, because we do that oftentimes when we're imaging the liver, that can actually diminish your portal vein flow. Don't worry about venous pulsatility index, cross that off. So here we're seeing again, normal portal venous flow. So above the baseline, one direction, hepatopedal.
What does this have to do with the tricuspid valve?
So patients who have severe tricuspid regurgitation,
Oh, yeah, the hepatic vein.
similar, yeah, so it affects the hepatic veins.
Mhm.
But then that also gets translated through the liver into the main portal vein. So if it's very severe, we can actually pick it up pulsatility in the portal vein now.
I saw one the other day that had reversal. It's just backing up further and further.
Yeah, it just backs up further and further.
Yeah. I
So
saw
yes, the
one
hepatic
with
veins are gonna
the
have very
hepatic vein.
pronounced flow reversal,
I think you can tell what.
but they can work its way all the way back into the portal system as well. So when you do see instances where you have retrograde flow below the baseline where it's bidirectional, so that portal flow now is going in two different directions. You just have to start looking at other factors, other things that are going on with this patient. You know, do they have cardiac disease? If they don't have cardiac disease, then they're probably entering into or they do have portal hypertension now. So pressures are starting to elevate in that liver and they have liver disease or something going on that's causing pressures within that portal vein to elevate and cause that reversal of flow. So when we have increase, we're going to talk extensively about portal hypertension. Kind of got a little ahead of myself, but so here we're seeing main portal vein and it's branching. So this is a nice, beautiful picture of that main portal vein entering into the liver at the porta hepatis, and then splitting into your right and left portal veins. Here we're seeing the right portal vein, some of its branches. So that right portal vein will split further into various segments. It's a nice picture. Main portal vein entering into the liver, branching into your right and your left portal veins. So one is your right portal vein, two is your left portal vein, three is your main portal vein. Be aware that, you know, your right and left portal veins will further split, bifurcate, and they'll continue to branch as they course and extend out through the liver. Start talking about the vasculature within the liver. One thing that we should note is that the portal veins have bright echogenic walls, so we can differentiate them from some of the other vessels, namely the hepatic veins, which are draining the liver. We can tell portal vein from hepatic vein by the echogenic walls that are on the portal vessels. So portal vessels, the portal veins, as they continue to branch throughout the liver, will have bright echogenic walls, whereas the hepatic veins that are draining the liver do not. So you really don't even see walls to the hepatic veins, really. Unless your patient's super thin, you know, and it's a really clear scan. So portal vein diameter. So portal vein is measured where it crosses anterior to the IVC. So normally that diameter should be less than 13 millimeters, you know, with quiet respiration. So we like to measure that portal vein if we can outside of the liver before it enters into the porta hepatis. So we said the porta hepatis is the area or the region of the liver where the vessels enter and exits, as well as the vessels enter and then the bile duct exits the liver. So this is again is referred to as the portal triad. So the DMS students are familiar with the portal triad. There's three things that make up the portal triad. So these are the three amigos. You know, they course throughout the liver and they all run side by side and parallel each other. So we have the hepatic artery and the portal vein. So those are both hepatopedal flow, bringing blood flow into the liver. And as they course into the liver, they continue running along side by side each other. So the flow direction in both of those vessels is going to be in the same direction. So it should all be in the same direction. And then the opposite direction is the drainage of the bile. So bile ducts coursing along with the hepatic artery and the portal vein, just in the opposite direction. This is the ultrasound image now showing, here's our hepatic artery, our common bile duct, the main portal vein. Again, your three amigos there, all hanging out. That common bile duct and the hepatic artery should be anterior to the main portal vein. Again, we'll put color flow on to try and distinguish common bile duct from hepatic artery. So in terms of the vessels that drain into the main portal vein, we have the splenic vein. So it's posterior to the body and tail of the pancreas. It lies anterior to the aorta and the superior mesenteric artery. And it courses from the hilum of the spleen. Superior mesenteric vein runs parallel to the SMA, to the artery. The SMA is to the left of the superior mesenteric vein. These are best seen in the longitudinal view. The left gastric vein, or also known as the coronary vein, enters the superior aspect of the portal vein near that portal splenic junction. So that left gastric vein or the coronary vein shunts blood from the portal systemic circulation in cases of portal hypertension. So that coronary vein can become large, become dilated, and act as like a collateral channel to kind of take some of the pressure off of the main portal vein in cases of portal hypertension. So when we get into portal hypertension, we'll see what we look for. We look for these varices or dilated vessels or dilated veins that indicate portal hypertension. And then we have the inferior mesenteric vein, which drains into the splenic vein. This is just demonstrating a nice splenic vein. So a nice transverse, again, pancreas, long splenic vein coursing posterior to the body and tail of the pancreas and draining into that portal confluence. In terms of flow direction, we still refer to the splenic vein as being hepatopedal because that blood flow is flowing towards the liver. So normal flow direction should be coming from the spleen, in this case, up towards your transducers or lead towards you, towards that portal confluence and towards the main portal vein. So in this case, if we're in this plane, in this view, it should be above the baseline. So again, we're going to be looking at flow directions for the splenic veins, flow directions for the superior mesenteric vein, flow direction for the main portal vein, because again, this could indicate the development of disease. So things like cirrhosis and portal hypertension will alter that flow direction. So now we're seeing that sagittal view. So this is IVC, or well, they're showing saying this is the aorta. The IVC, right? But anyway, aorta or IVC and sagittal, we know we're in a longitudinal plane. With that pancreas now, it's the superior mesenteric vein that's draining into the portal confluence. So again, just be careful. Yeah. Oh. That looks like aorta. It's definitely aorta. Definitely aorta.
Yeah.
It's just perfectly uniform, you know, it's not wiggly or squiggly or. Yeah, it's like, it's perfectly straight. That's definitely aorta. Like that's. You know. So what goes in must come out. You know, that's an important thing to just think about when we're talking about liver disease or any organ. When blood flow goes in, blood flow must come out. And if it doesn't come out, it's going to cause problems. So that's when we get into Budd-Chiari and some of those other conditions. So liver drainage. So drainage of the liver occurs through the hepatic veins now. We have 3 hepatic veins, a right, middle, and a left hepatic vein, draining the corresponding segments of the liver. Again, those hepatic veins are utilized to break the liver into further break the liver into additional segments. And then the flow direction when it's draining out of the liver is referred to as hepatofugal. So fugal meaning away from the liver into the IVC. So the hepatic vein waveforms are very unique. They have a W-shaped waveform where there's an antegrade systolic and a diastolic, antegrade systolic and diastolic component, and then a retrograde A wave where the atria actually contract and then push the blood backwards when the atria are contracting. This is just showing now the hepatic veins as they drain into the IVC. Your right, middle, and left hepatic veins. So when you start scanning hepatic veins, it's really superior. It's really literally just below the diaphragm. So you guys know that in echo, like when you're scanning, when you're doing your subcostal view for the IVC, you can sometimes see the right hepatic vein right there. So it's right near the heart, you're right near the diaphragm. So
Is that the one that we Doppler, the right one?
yes, yeah, if you
That's
were
the
to
one that we're
Doppler,
seeing when we are left?
Yep. That's right, like it's right before. Left is gonna be a little further down. So look, the left one's kind of over here, the right one's like
Oh,
right,
wait, yeah.
right up there.
It does. Maybe we get the IVC. Oh, but that's not the IVC. Oh,
Well, it is, IVC is down here.
wait, but it says that's the right hepatic.
Well, it feeds into the IVC now.
Oh, this is right, yeah, feeds into the IVC, so these are all kind of drain, IVC's kind of like right.
So you
It's
just-
not a super clear picture of IVC. There you go, there's IVC, there's your right, middle, and left.
Wait, that's that. So the one we Doppler is the middle one.
Well, this is a transverse view, so like in sagittal, it looks a
Oh.
little bit, so here's your side, so this is kind of what you guys are seeing,
Yeah.
and the heart's up here.
We're flipped the other way.
Yeah, you guys are flipped the other way.
Oh,
Oh,
the
because
probe
the
opposite.
oh my god.
Yeah,
And I can't
Echo
do
is
this.
flipped, everything's flipped, so they're like, they look at it upside down. Not upside down, I guess you guys are more true.
Heart's on the bottom right. Left is, well, our right, the right of the screen, and now it's on the left. Oh, look at the R right. I was like, it's not the right. I know, that's why I'm confused. That's what confused me. What's R said?
Right anterior, so this is just breaking into
Is
the,
the anterior
yeah,
posterior?
the anterior posterior for the right lobe. Yep, segments of the lobe. So with the hepatic veins, when you try and image them in transverse, so we're gonna be imaging them in transverse, you may not always see all 3 of them in one view. So oftentimes you can get, the middle and the left come in nice and clear, the right one you're not really visualizing, you might have to angle out towards the right to be able to have it come in. So sometimes we just get a view like this bunny sign where we're seeing the middle and the left hepatic veins. The middle and the left will oftentimes come together and form a common base or a common stalk that drains into the IVC. So just be cognizant of that. So here's the left hepatic vein, middle hepatic vein, they're coming together, and there's a little common piece as it jumps into that IVC. More transverse images, and then a coronal image. So coming from the patient's right, imaging back. Some more pictures, hepatic veins. Yeah. And then this is now that sagittal, so we're gonna practice coming from coronal, seeing if we could see the IVC and then the right hepatic vein draining in. Because when it comes to Dopplering, we're gonna have to get nice color pictures for, your hepatic veins to prove that they're not thrombosed, that their flow direction is proper, everything's flowing in the proper flow direction, draining out of the liver. Particularly with that right hepatic vein in that transverse view, oftentimes it's gonna be perpendicular to your ultrasound beam, so when you put your color on, it's gonna be very hard to fill that vessel with flow. It's gonna be very hard to obtain a Doppler tracing. So we're gonna practice some other views or some other techniques to try and get good color flow. And the main one is coming from a more coronal approach in sagittal and having that right hepatic vein draining right in. And if it is truly, patent, it's gonna fill right up with color and you'll be able to get a good Doppler tracing. So now we're getting into some of the waveforms. So we said, they have the characteristic W waveforms with a small component when the atria contract, that's above the baseline. So again, this should be below the baseline, should be flowing away from the transducer, draining into that IVC. So everything should be draining from the liver down towards that IVC. So in this case, if we're making, way blue, everything should appear blue. And this was just showing the different components of the hepatic vein waveform. So this is a normal hepatic vein Doppler waveform with your systole, diastole, and then the atrial contraction seen above that baseline. So it is kind of like a triphasic waveform. So sometimes you'll see it in some of the literature as being triphasic. Again, normal hepatic Doppler waveforms. We're trying to get those W's.
You Doppler each hepatic vein. Or is it
Upside down bunny. Yeah, we do Doppler. As part of the liver study, yeah, you would Doppler all three of them.
And they should all look like that.
Yes, yeah.
So is
It's
this,
gonna vary a little bit because of Doppler angles, since their veins are not like, lining things up with like 60 degrees or anything like that, so. But they should have the same general appearance. Should be away from the liver, should be draining the liver. So same thing with the main portal vein, deep inspiration can blunt the pulsatility in the hepatic veins. So instruct the patient to just take a normal breath in and take a breath out and just kind of pause their breathing to obtain the waveforms. Because again, with the breathing, the liver is going to be shifting up and down, make it a little bit challenging to get Doppler waveforms. And then we said patients that have right-sided heart disease, or congestive heart failure, will see increased pulsatility in the hepatic veins with exaggerated retrograde. So that A wave component is going to be exaggerated. So here's again, someone with congestive heart failure, CHF, that part that's above the baseline is going to be severely exaggerated. And with that, we also see now increased pulsatility in the portal vein. So normally the main portal vein, again, should all be above that baseline, but we're seeing bidirectional flow. So that's important to know your patient's, full medical history, because otherwise you'd be calling this patient, as having possibly a cirrhotic liver with portal hypertension because we're seeing bidirectional flow. But sonographically, you're looking at that liver and you're like, that liver doesn't look bad at all. I can see all the vessels, there's no increased echogenicity. It doesn't look fatty. It's normal size. Their liver functions are normal. Like, what's going on here? But this is just a result of their having underlying cardiac issues. And then patients with right heart failure, with tricuspid regurgitation. Again, we're seeing inversion of that systolic peak. So very severe, tricuspid regurg with congestive heart failure. Again, we can also then pick it up on the portal side of it, on the other side, with the blood flow going into the liver. So now this is just showing your portal triads, so your portal veins, hepatic arteries, and bile ducts as they course through the liver in relation to the drainage, the hepatic veins. No differentiation between hepatic veins and portal veins. So we said that portal veins have the thick echogenic walls. So that's this echogenic sheath that surrounds the vessels that makes them easier to visualize or differentiate from hepatic veins. We talk about the size, the portal veins are gonna get larger as you get closer to the porta hepatis, because that's the origins of the vessels. But the hepatic veins, they're gonna enlarge as they get towards the IVC. Hepatic veins, they course longitudinally across the liver, whereas, longitudinally, whereas the portal veins, run transversely across the liver. So these guys are running up and down the portal veins. The hepatic veins are running up and down longitudinally, whereas the portal veins run more transversely. There's what it would look like on ultrasound. So you can kind of differentiate portal vein, because we got the echogenic walls to it. And then hepatic veins, essentially look like they don't have any wall to them. So that's why they refer to them as being naked. So there's hepatic vein. So it's sagittal view again. Now we're in sagittal liver, so you can tell this is a portal vein, got the echogenic walls, and then hepatic vein. It's a nice picture for IVC, and then right renal vein there. So flow direction, hepatopedal and hepatofugal. So all the vessels that drain into the portal vein, we should be characterized as hepatopedal. So superior mesenteric vein, splenic vein should all have blood flow flowing towards the liver. So it should be hepatopedal flow. Hepatic veins should be hepatofugal, draining into the IVC. Rosenstein.
Yeah.
You can't what?
Keep my eyes.
Keep your eyes open.
It's like a bedtime story.
Oh, we're at 75 right now.
I think it's a good, I think
That's
that's
like
like
almost
almost
half
half
it.
2 more weeks.
Well, one
Yeah,
of
we
the
have-
weeks is-
We do this, finish this next week. I'm sorry,
So last week is transplantation, though, right?
transplants. Yeah, liver transplants. Yeah, yeah. So it's this and then liver transplantation in the next one.
Oh, and that'll all be on your side.
Yep.
My eyes are already crossed. I have no idea. Yeah, it's just they all sound the same. We're not portal vein, so it's hard to hepatic vein. It's a lot. It's not confusing. Right, yeah, we said that's good.
Yeah.
Oh, it's about to come. Wait, what did
Yeah.
yesterday? I don't know, we're starving myself. Seeing you.
I know, I'm
I know, I'm so hungry. Yeah, I tried, I did not
Alright.
eat.
Me neither.
food. I didn't chew gum either.
We could tackle portal hypertension next week.
Yeah.
You guys got it.
iPad up, I chew.
Either way. We'll see.
It's Friday.
It's always a Friday.
I know, but I said end of the whole week,
Tired.
it's like, you're barely paying attention.
You're barely hanging on.
Then you don't even know.